podcast. Today is June 16, 2020. I'm Rifat Mannan in Philadelphia, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston now. Today, we are excited to host this cytology case discussion featuring three cytopathologists, Dr. Jalal Jalali, Dr. Norhi Vergara, and Dr. Zubair Bellows from University of Pennsylvania. I will pass on to Dr. Bellows, who is going to introduce the speakers. Over to you now, Dr. Bellows. Thank you for joining us.
Thank you, Emilio and Rafat. I have to tell you that this platform, Pathcast, is one of my favorite virtual platform for teaching and education because it goes throughout the world. And it's really is all these experts and even younger faculty have joined and really delivered amazing cases. And I'm such a big fan of it. So I'm not going to take much time and just introduce my two excellent colleagues who have joined me today to do these three case presentation, which really kind of honed down some things very important that we really need to think about. Dr. Vergara is also was a fellow in cytology at Penn, and he is a assistant professor. His areas of expertise definitely is cytopathology, but he focuses on geopathology, which includes both histology and cytology. Dr. Jalal Jalali, who's also an assistant professor, he was also our fellow, so I'm very proud to say that our fellows do stay here back as faculty. Jalal is expert in head and neck and endocrine, and he does both cytology and histology. So I'm going to switch it over to Dr. Vergara. Norhe?
Yes, thank you, Zubair. It is my honor and pleasure to be part of this series. I happen to know also Rifat and Emilio from, we were in the same program, even though we were not at the same time, but we came from the same residency program. So without further, I'm gonna start my presentation. It's gonna be about the urinary tract, very interesting case that I wanna share with you. I'm excited about it. I don't have any relevant financial disclosure to make. And so our interesting case is going to allow us to see our practical approach to it, and we're going to discuss this case and including differentials. We talk about our experience with the PARI system for reporting urinary cytology. It's been over a year since we started using it. What we consider to be the role of Eurovision in urine cytology, what literature tells us. And even though it sounds obvious and redundant, but how it is important to correlate the cytology result with the histology finding in this era of specialization, where even here some sign out the cytopathology from different from the histology. We don't want to end up with two different diagnoses for a patient. So I'm gonna present this case. Is about a 70-year-old female. She has a history of bladder pain syndrome. That's another name for a interstitial cystitis, a chronic inflammatory disease, typical of the middle to elderly women, with a constellation of symptoms which include urinary frequency, nocturia, urgency, and suprapubic pressure and pain that is released. It is caused by bladder filling, but released when patient release the urine. As you can see, the pathology role for the management of the interstitial cystitis consists of first to rule out other forms of cystitis, even though the histologic findings and the cystoscopic findings are not entirely specific, but that correlation could actually help to anchor the diagnosis for the patient. And the most critical role would be to rule out carcinoma in situ. Consider that some of the symptomatology could be very similar, particularly for primary urothelial carcinoma in situ. So our specimen was a bladder washing, and the first thing we see is like a very cellular specimen. Closer magnification, we can see that at least part of that cellularity is due to a mix of acute and chronic inflammation. Also caught my eye this cell here with cytoplasmic vacuole and nuclei push out to the periphery. That just by itself could just be a sign of degeneration, but already should be in the back of your mind, cells like this. And by now, most of pathologists are aware or familiar with the urinary, with the Paris system for reporting urine cytology. And one of the strengths of this system has been the, now in contrast to prior scheme, now we have a set of criteria for the atypical urine cytology. And a lot of weight is given to the high NC ratio, knowing that is a very common feature of high-grade urothelial carcinoma, and that is the purpose of the urine cytology, to diagnose high-grade urothelial carcinoma. So as a required criteria, the NC ratio of at least 0.5 is required, in addition to other one of the other two criteria, hyperchromasia, coarse chromatin, or irregular nuclear membrane, and the lack of a reason for that atypia, such as lithiasis, stones, and treatment. But even though the criteria is there, it's just the interpretation of the criteria what sometimes is more difficult, associated also with the common degeneration changes that we see in this kind of specimen, as well as we like to believe that we're good at recognizing the NC ratio, but study has found that we're not so good at determining what it is a 0.5 or 0.7 NC ratio on a cell. But particularly this cell here, I can see it has very dense granular cytoplasm. It looks urothelial to me, and at least I think it has a 0.5 NC ratio. However, the nuclear membrane is still smooth. It has some prominent nuclei. The chromatia, I would say, is more hypochromatic instead of hyperchromatic. But in our experience, at least in our center, we have found that some high-grade urothelial carcinoma also can have some hypochromatia. Even more abnormal, we found this as in an arrangement where the cells have a peripheral place nuclei. Some cells, you may say, that is at least approaching the 0.5 NC ratio, and that fact that those features are already concerning, as well as other cells with a cytoplasmic vacuole and the nuclei pushed out again to the periphery. This one particularly has some membrane irregularity. And when I see those features of cytoplasmic vacuole and push out nuclei, and that as in a configuration, I had to think of the cytologic feature of micropapillary variant of urothelial carcinoma, which has been described previously. And here is a different case that I want to share with you. Here we have this three-dimensional fragment, which seems to be branching now, like real papillary. The nuclei are peripherally placed. There's a lot of vacuolization of the cytoplasm. Some of the nuclei seems to have some irregular nuclear membranes. However, many of them has very smooth and elongated appearance, very blandish. The cells has this significant amount of vacuoles, and the cytoplasm is moderate to abundant, which would challenge, in a way, this NC ratio criteria for the Paris system. In their study, they found the formation of this micropapillary with the peripheral eccentric peripheral place nuclei and this cauliflower-like structure with the cytoplasmic vacuoles were correlated better with the histologic finding of micropapillary variant urothelial carcinoma. You can see the lacuna filled with nest with peripheral place nuclei and moderate to abundant cytoplasm, and consistent with the features of micropapillary urothelial carcinoma, which is known, similar to other organs, to be associated with early advanced stage, more lymphatic lymph node metastasis, and poorly response to BCG. And as such, whenever the features are there, either in cytology or histology, we should comment on it, because the discussion about earlier cystectomy should be considered for this patient. So going back to our case, with the features that we described before, we feel that these are beyond the negative for high-grade urothelial carcinoma, and however, they're really short for a suspicion for high-grade urothelial carcinoma, and as such, we classify this as atypical urothelial cells. Briefly, I want to mention our experience with the Paris system. As I said, about a year ago, we met with the GU group, the clinical team, and we proposed this classification, which already has been for some years out now. But consider the most important is having a common nomenclature that we can understand each other. So we presented this to them. They were really excited, particularly when we told them that this percentage of cases that in the past we call a urothelial fragment or fragment of urothelial cells in which we have an expedite that cell neoplasm cannot be ruled out. So most of these patients will actually be taken for cystoscopy. And however, in their experience, similar to the literature, the risk of finding a real neoplasm in this case it was minimal, if none. So as such, with the Paris classification, all these fragments will not mentioned anymore, and as such, we help to avoid a unnecessary cystoscopy on this patient. Going back to our case, we do have a Eurovision in our lab. Unfortunately, we do this in a clinical setting base. It's dictated by the clinician, and this patient, the Eurovision results were negative. Particularly a case like this pointed out that how the Eurovision should be used. It is known that the Eurovision has a higher sensitivity than cytology, but that's actually more based on the probability of finding a low-grade urothelial carcinoma, which is known that for the most part it can be rarely seen by cystoscopy, and as such the management is not going to be impacted by finding those earlier with a Eurovision. Similar, the high-grade urothelial carcinoma cytology is so good and specific, and our positive predictive value is in the 90. So having a Eurovision in this setting is only going to add unnecessary cost. In contrast to the indeterminate category, it is suspicion for high grade, particularly those patients that had already history of high grade that's been treated. Those the treatment effect can be very difficult at times and only fall short to a suspicious diagnosis. And then with the the use of the Eurovision, that could be a confirmatory of the high-grade urothelial carcinoma. But even more useful could be in the present cases like this one, where we have atypical urothelial cells and a cystoscopy that doesn't find anything significant or is negative. Just the presence of AUC with a negative Eurovision will be reassuring to the clinician that most likely this is not related to a high-grade urothelial carcinoma, and then biopsy will be necessary. However, in this case, we do also have a histologic correlation. It was done concurrently. And what we can see here is the lamina propria is very inflamed, acute and chronic. And then we have this tubular structure and in a reminiscent of a papillary lesion here, in contrast to a real papillary neoplasm, which should have a delicate fibrovascular core. Here we have like a broad base, hyalinized cores, and they seem to be like now only by a single cell. The cells have this cuboidal appearance, very eosinophilic cytoplasm. Some have prominent nuclei, as we saw in our case in cytology. Then we see the other pattern with some more tubular structure filled with these cells, eosinophilic cytoplasm with a hot nailing appearance. The structure surrounded by this hyalinized basement membrane, and the stroma is inflamed and with edema. Some of the cells have high NC ratio and more degenerative type atypia. Some of the cells on the surface have also these cytoplasmic vacuoles that we saw. A different area was also biopsy, and this shows how this lesion can be multifocal. In this, the tubular structure seems to be lined by these cells that have this endothelial-like appearance, and as such, you can see how a vascular lesion can be entertained. However, all the features that we described, together with the inflammatory stroma and the confirmatory immune stain for PAX-A, is very typical of a benign nephrogenic adenoma, a lesion that it is most commonly incidentally found, but in occasion can simulate a papillary lesion, as such even carcinoma. The cytology of this nephrogenic adenoma has been long time described, and so similar to what we saw, it can be some gland-like clusters, have palisade and community cell border. Cells are polygonal to columnar. Some can have a scan a cytoplasm and a high NC ratio. Others can have abundance, a clear cytoplasm. The nuclei can be active, like a prominent nuclei, but they shouldn't be mitotic figures, and the atypia should be not obvious, or if so, more degenerative-like. Can be some cytoplasmic vacuoles as we saw, and the differential will include reactive urothelial cells, adenocarcinoma, including clear cell adenocarcinoma, and I would add to it the micropapillary variant of urothelial carcinoma, because some of the features correlate with that. So the histology can have multiple histologic pattern. As we saw in our case, the forming pseudopapillary or papillary structure, but with a broad base, can have the cystically dilated tubules. Some of those tubules can be filled with mucin-like or with thyroid-like substance. Some have a small tubular pattern. Characteristic is the inflamed stroma with edema, and it has a very distinct immunohistochemical profile. They are CK7 positive. They express the tubular marker PAX2 and PAX-A. Most of them are positive for racemase and negative for P63 and high molecular weight cytokeratin. So that, together with a small tubular morphology in a male patient, can give to a differential diagnosis of prostatic adenocarcinoma. We discussed with a urothelial carcinoma, papillary, or even nested variant, single ring cell adenocarcinoma and clear cell adenocarcinoma. We saw also how a vascular lesion can be entertained in the differential. So in summary, we presented a challenging case. We discussed our approach to it, including differentials. So we briefly comment on the PARIS system for reporting urine cytology here in our center. What we believe should be the role of Eurovision for clarifying atypia in urine cytology. Our case was a nephrogenic adenoma. We saw the cytology, histology, and immunohistochemical features and differential diagnosis. And our case correlated or showed the importance of of correlating urine cytology, since the histology of the nephrogenic adenoma really explained well what we called before an atypical urothelial cells, and as such, we put an end to that atypia correlated with this case. So this is my daughter, who at the time was not 5 years old and completely immersed on online learning experience. And at this point, I would like to take any question, or I'm not sure if we're going to do that later, but I would like to, if there are no questions, then I will pass this to Jalal.
sorry. So I was saying that I'm a head and neck and endocrine and cytopathologist. I also sign out at Penn. So thank you, Emilio and Rifat, for this kind invitation, and Zubair for the kind introduction, because I really enjoy myself watching podcasts. So I'll use this opportunity to present two cases that are similar to each other, but also different. So here's the first case. It's from a 37-year-old woman with a lateral neck mass. As you can see here, this is a hypoechoic lesion. It was present in level 2A, and it is also producing this acoustic enhancement that is suggestive that it's a cyst. A similar patient also presented with a neck mass. He's a 48-year-old man and presented with a left neck mass that he noticed about a month ago. And as you can see here, this mass is a little bit different. It's also hypoechoic. It also has this hyperechoic area in the center. It's not producing any acoustic enhancement. It was present in a similar location in level 2A. So this was more consistent potentially with a lymph node, but it also has some cystic degeneration. So when presented with these neck masses that have cystic components, how do we approach these cases? First of all, you have to think about the age of the patient, because when the patient is in the pediatric age group, most of what you're dealing with are congenital lesions. Sometimes you'd have infected lymph nodes, but for the majority of the cases, these will be congenital lesions such as thyroglossal duct cyst, branchial cleft cyst, and thymic cysts. On the other hand, when the patient is an adult, you have to think about metastatic squamous cell carcinoma, because this is, especially in patients above the age of 40 or 50, this will be the most common presentation. However, sometimes these patients do present with congenital abnormalities if those lesions become infected. The location of the lesion is also very important. So you have to decide if it's a center lesion or in the midline, or if it's in the lateral neck. And I'll go into more details about that in the next slide. The clinical symptoms can give you a clue of what you're dealing with. So, for example, if the patient had a recent upper respiratory tract infection, these could be infected lymph nodes. If the patient is presenting with ear pain or a autoria, some discharges from the ear, you can think about the first branchial cleft cyst. Also, if the mass is moving when the patient is swallowing, you can think about the thyroglossal duct cyst. And then radiology. We work closely with our radiology colleagues, and we always have to depend on their differential diagnosis when they're approaching these cysts, because it's very important that we correlate with what they think the cyst is and their differential diagnosis. So talking about the differential diagnosis depending on the location, you can see here for the center lesions, we're mostly dealing with a thyroglossal duct cyst, a dermoid cyst, or a thymic cyst, but also can be a ranula. But don't forget that level 6 lymph nodes are also in the center compartment of the neck, and those can drain from the thyroid. So if you're dealing with the thyroid malignancy, it can present as a solid orocystic lesion in the center of the neck. On the other hand, on the lateral component here, the main one to think about in level 2A is a branchial cleft cyst, but you can also see that the tail of the parotid gland and the submandibular gland are present in this lateral location, as well as lateral lymph nodes. So here's the FNA from the first case, and you can see here that it's a squamous lesion at first glance. These are certainly polygonal cells with with low NC ratio. They have a dense cytoplasm. Some are nucleated, but you can see that some are losing their nuclei. They are anucleated squamous cells. But for the most part, they don't look that atypical. As you can see here, this is the pap stain, again showing very nicely polygonal cells with different degrees of degeneration in these cells. So the differential diagnosis for such a lesion, you'd think about a benign squamous cyst, and we're not seeing the lymphoid component here, but here's the follow-up surge path, where you can see that the needle tip actually hit the center of the lesion and did not touch the wall. So that's why you're dealing here mainly with a squamous lesion, and you're dealing with the different degrees of degeneration of these squamous cells and not seeing the lymphoid component of the wall. So this was a diagnosis of a branchial cleft cyst. On the other hand here, you can see the squamous cells or the cells that are seen from case B, from the 48-year-old man, are quite different. They still appear squamoid, and they have a higher NC ratio, as you can see, and definitely higher degree of atypia. And you can see that there are some inflammatory cells in the background. And the pap stain also show these very atypical looking cells with different shapes of their nuclei, different degrees of hypochromagia, and abnormally shaped squamous cells. You have to remember that squamous cell carcinoma is one of those carcinomas that not always show high NC ratio. So sometimes you do have to depend on the degree of abnormal shapes of the nuclei and abnormal shape of the cytoplasm to make the correct diagnosis. So depending on where the needle hits, you can see here that different areas may show up on your cytology specimen, because these neck metastatic squamous cell carcinomas frequently have areas of necrosis. So you can see here that sometimes the needle will only give you areas of necrosis if the needle hits a necrotic cystic component of the tumor. If it doesn't hit a very cellular component of the lymph node, you may end up with only abnormally shaped atypical squamous cells and some degeneration here in the background. But also the needle may hit a cellular area, and you're fortunate to have a definitive diagnosis in such cases. So that's why you have to be very careful when you see some atypical squamous cells in a background of necrosis, and not jump to the conclusion that this is a squamous cell carcinoma. But because a lot of times what happens in the branchial cleft cysts, especially from older patients, they get infected, and that's why they present later in life. And in that situation, you may find some degeneration and that resembles necrosis, and some atypical squamous cells. And in that case, you have to diagnose atypia, atypical squamous cells, and not be definitive. But always search very carefully for definitive squamous cell carcinomas, because that, especially in older patients. So here's the summary of the first case. The radiology was suggestive of a cyst with some acoustic enhancement. The cytology was very benign appearing, and a follow-up surgical pathology was consistent with a branchial cleft cyst. On the other hand, the second patient had also a neck mass in level 2A that was radiologically more suggestive of a lymph node, and the cytology was malignant, and the follow-up surgical pathology was certainly squamous cell carcinoma. So this gives me a chance to talk a little bit about branchial cleft cysts. These are developed due to abnormalities in the branchial arches. So you can see here that we have, as human develop in embryos and in the fetogenesis, we have 6 branchial arches. And here we're showing the first 4. So the first one developed into the ear. You can see here that they're covered with ectoderm and lined with endoderm. And this end up developing, becoming an ear. However, if the other arches, the second, third, and fourth, do not regress completely, they may develop into a branchial cleft cyst, which is the most common type of cyst, presenting more than 90% of branchial cleft cyst, and it's usually located in the level 2A. And level 2A is important because nowadays we are faced with an HPV epidemic, and a lot of these patients present with a neck mass as their initial presentation. So you can see here in this study, about 50% of patients with HPV-related squamous cell carcinoma can present as a neck mass in level 2A, which is similar to a branchial cleft cyst, and it's important in the differential diagnosis. These are important to recognize because HPV-related squamous cell carcinomas tend to have a better prognosis compared to the smoking-related squamous cell carcinomas that develop in the oral tongue. So one way to identify these is P16, because these human papillomavirus have 2 oncogenes, the E6 oncogene and the E7 oncogene. And as you can see here that the E7 oncogene deactivate the retinoblastoma protein. And once that is deactivated, it will upregulate P16, which can be used as a surrogate marker for HPV. Nowadays, any squamous cell carcinoma from the oropharynx or of an unknown primary, we are required as pathologists to test for HPV, and the CAP, the College of American Pathologists, recommends to use more than 70% strong nuclear and cytoplasmic staining in tissue to determine that that is positive and HPV related. However, in cell blocks, this is not always the case. As you can see here, this is a cell block, and this is P16 that was done on the cell block that is only showing partial staining with P16. It is strong nuclear and cytoplasmic, but the question is, does the cutoff applies here? Are we using the same cutoff as 70% in cell blocks? And the answer to that question is 70% actually. If it is used in cell block, it will miss a lot of cases of HPV-related HPV-related squamous cell carcinomas. You can see here that there are different studies that looked at different cell block cutoffs for P16. Some have used even any staining to be consistent with P16 positivity in cell blocks. But most studies, based on a review that I worked with Zubair and some of my great colleagues, Mohsin and Khurram, Shafiq, we showed that the cutoff most likely lie between 10 to 15%. So if you cross that threshold of 10 to 15% staining, strong nuclear and cytoplasmic staining in cell block, that would be most likely consistent with HPV-related squamous cell carcinoma, and it would be consistent with a positivity in surgical pathology specimens. However, a negative staining in cell blocks should be repeated in surgical pathology specimens, because as you can see here, the sensitivity can be quite low, and you can miss some cases if you call those negative in cell blocks and do not repeat the tissue staining. So here's an algorithm when faced with a neck mass. You determine whether this is approachable by FNA. If it is, you do a rapid on-site evaluation, and if it is suspicious or diagnostic of squamous cell carcinoma, you take extra passes to create a cell block. So once you have a final diagnosis of squamous cell carcinoma, you look at the cell block to see whether or not it has adequate material for staining. If it doesn't, then preferably recent studies showed that molecular testing in the HPV rinse can be the most helpful to correlate with HPV status. But if your lab is equipped with performing P16 on liquid-based preparations or smears, you can go ahead and do that, although it has to be internally validated. But in most cases, the best approach is to have P16 performed on a cell block when you have it, because not all labs will have the HPV molecular testing available to them, and P16 is widely available. So once you do P16 on cell blocks, if it is negative, then you should repeat that on tissue. However, if it is positive, and it's positive in more than 15% of tumor cells, and also based on an internal validation cutoff that is determined by your lab, then you can call it P16 positive. In a recent work that I've done with our current cytopathology fellow, Sharon Sung, both of us showed that the P16, when it's any staining, it can correlate with positivity in tissue specimens. However, if you use very low threshold, less than 15%, that could be equivocal, because sometimes if you call any staining in cell block, that can increase your false positive rate. So you have to be careful with that, and probably repeat the tissue staining if the staining in cell blocks is between 1 to 15%. However, if it's more than 15%, then most cases would, and most pathologists would agree that that would correlate with tissue positivity. So in summary, head and neck cysts are common, and clinical presentation may give a clue to the correct diagnosis, as I've shown in these two cases. Metastatic squamous cell carcinoma to the head and neck frequently present initially as a neck mass, especially in patients with a primary oropharyngeal primary that is HPV related. And as you can see here, nowadays, HPV testing is required for any metastatic squamous cell carcinoma from the oropharynx or an unknown primary, as well as on the primary site if a metastatic site is not available. The cutoff for P16 staining in cell blocks is definitely significantly lower, and that has been shown by multiple studies compared to surgical pathology. So definitely you want to validate your internal cutoffs, but most studies out there show that the cutoff probably range between 5 and 10 or 15%. And that's it for my presentation. Now I'll hand it off to my colleague, Dr. Zubair Balouch, and he's also my mentor. And thank you, and we'll take questions at the end.
Thank you, Jalal. Thank you, Rifat and Emilio, for again giving me the chance. This is the third time, and I promise this will be a major hiatus, so people don't get sick and tired of hearing me. So what I am presenting is something that it's not a diagnostic dilemma, but it really taught me something very important. And when you are training as a fellow or as a junior faculty, the best thing for those years is that you think you know everything, and then you get hit by a case and you go like, oh my God, I need to start my residency again, not even the fellowship. So this is a case which taught me something important, which was about that cytology diagnosis cannot be made in a vacuum, because you're looking at such a small number of tissue sample, which can be just scattered cells without architecture, that it can really give you a 360 spin to your head, and you feel basically dizzy and I think I really learned from this case. So I'm going to share, so I'm going to title this as clinical history is as important as your diagnosis. So this was the case. This was actually was sent to our cytology bench as a second opinion case. This was a 52-year-old woman who had an ultrasound done, which showed a left thyroid lobe occupied by a very predominantly ill-defined hypoechoic structure, very, very suspicious looking. And actually, the radiology suspicion was that it's a malignancy, and they thought that this could be most likely an anaplastic carcinoma or lymphoma, because these both conditions kind of really take over the entire lobe or almost present sometimes bilaterally and give rise to this giant hypoechoic mass. And it's very typical of those, and they can also be very vascular. So this is what was the Diffquick stains on this. And as you can see that this looks pretty ominous looking from this point of view. There is a lot of these very ugly looking spindle cells with very, very pleomorphic nuclei, and some of the cells have this really lobated nucleoli. So even on the Diffquick, this looks really bad. This is kind of a cohesive cluster. But I can actually kind of guide you through a couple of the cells and say there's a very, very high NC ratio, and this looks really, really bad. Definitely spindle-shaped cells. And again, here is another group. You can see some of these cells are almost plasmacytoid, and there is a lot of nuclear debris in the background. So when you look at it without any history, you go like, wow, this looks pretty bad. And sometimes you think, why it's being sent for a second consult, because this is a really bad looking tumor. Now, this is the other areas of the slide, and this is further convincing because what you see here, which looks like almost like a tumor type necrosis. So there's a coagulative type necrosis. So there's a lot of necrotic debris and these kind of naked nuclei in the background. And again, those spindle cells and some really horrific looking nuclei. So here's a Diffquick stain, which looks really bad, and it's kind of confirmed by the PAP stained slides. Now, this is the other elements in the background. And this was very small area within the smear that I looked at, and suddenly I realized that there was these multinucleated giant cells, and some of them almost have this Langerhans type quality to them. You can see this nuclei kind of lined up on the edges of it, and these were little intermixed with those spindle cells. So this is all these three big giant cells, almost reminds you of kind of a little bit of a granulomatous type inflammation. Now granted, anaplastic carcinoma and other tumors which grow very rapidly throughout the thyroid can cause destruction of the follicles and can have all the thyroglobulins and colloid kind of spill out into the thyroid parenchyma and can have their own granulomatous reaction. So this one on the, as you can see on the left-hand side, these guys really dominated the picture. So I was still very scared about it. So for me, it was, it's a very challenging case. So I'm going to just show you within 24 hours, and that these good things always come in 2s and 3s. So this second case kind of hits my desk, and this is all coming to me. And I always complain to Dr. Gupta, and now I complain to my director, Cindy McGrath, sometimes that when I am on service, why I always get hit with these crazy cases. And she always laughs at me because that happens to her a lot also. So this is a now 35-year-old woman who is supposedly, and I asked the patient and she allowed me to give her history. She's actually a nurse who works in the ENT clinic in one of the satellite hospitals for Penn. She's 35-year-old, and suddenly she developed this very horrible compressive symptoms and severe anxiety. And then she goes in to radiology, and the radiologist said, you have a very bad looking mass. Let's do an FNA. So this is the FNA. Again, a lot of kind of a necrotic background, and you can actually start to see polys. And I was told that when you see polys with really bad looking cells, you think of anaplastic carcinoma. Now, what does not compute that she is 35 years old, and making a diagnosis of anaplastic carcinoma, you have to be very careful. This is another one, and you can see, again, this really lot of debris, polys, kind of almost an inflammatory background, looks very destructive even on this smears, and then you start to see these multinucleated cells. We did see a lot of papillary structures, again, funny looking spindle cells in the background. If I saw this in the lung, I will think about that this could be a granulomatous type reaction before I say this is a sarcoma. But then again, here are the bad cells in the background. Are those fibroblasts, or this is some kind of a spindle type tumor which is in the thyroid, and those are most likely anaplastic carcinomas. But you also have to think about metastatic tumors which can present in thyroid, and they can be spindle-shaped sarcomas or sarcomatoid carcinomas. This is the Pap stain slides. And once you start, again, I'm really not convinced that this is carcinoma, but I'm really afraid of these really funny looking nuclei with funny looking indentations within the nuclear membranes. Again, this necrotic debris, which almost looks like what you get from a squamous carcinoma. And we do know that you can get squamous differentiation in an anaplastic carcinoma. And anaplastic carcinomas grow slowly, and suddenly they go very fast and kind of invade into the structures. So the compressive symptoms can be seen in a giant, presentation of anaplastic carcinoma. This is another area, which is again a very smaller area where you start to see these granuloma or granulomatous type inflammation structures. Again, the polydust, which is still very concerning. Now here are the more normal looking follicular cells and some of the multinucleated cells. So 2 cases within 48 hours are on my desk, and now I have like a different follow-up for these cases. This is the first case. Original diagnosis made by the pathologist was suspicious for anaplastic carcinoma, and that's how these cases came here through the endocrine surgeon toward us. Now I called the surgeon and I said, is there anything additional in this history that can help me, because making a diagnosis of anaplastic carcinoma outright on a cytology is a little concerning. Because once you make that diagnosis, we are basically telling that patient that with 5 or 6 centimeter mass, you have only 6 to 12 months to live, because these tumors grow very fast when they present in such a manner. Now the history is that this patient had a bout of hyperthyroidism, which really caused anxiety and shakes, and even this patient couldn't sleep, sweat, and this was followed by hypothyroidism. And now she is on Synthroid, and this is all happened within the span of 4 weeks. So very short-term history. So this history to me raised the suspicion that there was something destructive, but that has caused destruction of the thyroid, but it's now more on a healing phase, but the patient is presenting with hypothyroidism. If this was anaplastic carcinoma, which would have invaded more vital structures and would not have this more of a milder history, which is hyperthyroidism followed by hypothyroidism. So I said, this does not look a malignant. Even I was shaking in my boots because I was still a junior faculty, and I said, my suspicion is that this is not anaplastic carcinoma. Even put a caveat that I cannot completely exclude it, but I really suspect this is subacute thyroiditis. The patient called me and said, doctor, I am not going to get a completion thyroidectomy, but I'm going to get a lobectomy. So this is the lobectomy. And the lobectomy does show you a very severely destructive process here, where there's just follicles left, and you can just see within the follicles there are macrophages. So this is a very rapidly degenerative and inflammatory process here. As you go down further, you can see beautiful granulomas with the giant cells, and there are areas where there is no follicular epithelium left anymore. This is all like taken over by this process. So this was very typical of subacute thyroiditis, which really gave me a very difficulty in my first case. Now, what happened to the second case? This is interesting. I call back again and get an additional history. The patient had a painful enlargement of the thyroid after upper respiratory symptoms. So remember, this is a very important history, which the clinician or even the radiologist failed to give it to the pathologist, or I don't even know the radiologist even got that history. Ultrasound was suspicious for carcinoma, and patient does have symptomatic hyperthyroidism at this point. So I called the surgeon and I said, this is not malignant. And this is actually one of our very ENT surgeons who's very robust ENT surgeon. And he said, are you sure what the hell you're talking about? I said, no, this is not malignant. This reminds me of a case that I had almost like 24 hours ago on my desk. And this looks like something which this is subacute granulomatous thyroiditis. And he said, okay, you know what? What we're going to do is call the patient back, and then repeat the FNA. So he calls the patient back. He calls me on site, and at that time, there was no thyroid nodules. The patient had completely recovered. So there was no FNA or second FNA or surgery needed. So this is something which is very important. And I really love to present these inflammatory cases because we talk about tumors and we talk in details, but we forget there is a whole batch of these benign and inflammatory lesions, which I find sometimes are more difficult than making a diagnosis of tumor. So I call these or differential diagnosis. And in this case, you can have your differential based upon cellular atypia, presence of spindle cells with pleomorphism, necrotic and inflammatory background, and granulomatous inflammation. So you can take all those 4 factors, put it in a box, and say you can see this in an inflammation. Take them again, put it in a box, and say these can be seen in malignant tumors. So this is a very short list. And I can make a couple of slides from this. There are inflammatory or reactive reparative changes in thyroid, definitely thyroiditis, but remember post-FNA changes. I have also seen cases where the patient had lobectomy done prior and now has a nodule, which is next to the prior surgical site of the opposite lobe where the suture was placed, giving rise to a vascular nodule. They put a needle, and it is actually a suture granuloma or reactive change in the follicle. So be aware, thyroid is a very vascular organ, and even the endothelial cells from the granulation tissue or reparative areas can look very funny. You have to think about granulomatous disorders, naturally any kind of infection which causes granulomas. And I'm from Pakistan originally, and I have seen actually TB cases of the thyroid giving rise to beautiful granulomas on FNA. Sarcoid and then Langerhans cell histiocytosis can give rise to histiocytic collections with eosinophils and can look like granulomas. You also have to think about neoplasms, papillary thyroid carcinomas, specifically the ones which are cystic, anaplastic thyroid carcinoma, medullary carcinoma because of the spindle cells, and even there are pleomorphic variants of medullary carcinoma which can give rise to necrosis. And then keep in mind secondary tumors to the thyroid, the metastasis. We have to give credit to Dr. De Quervain, who really described this, the granulomatous thyroiditis. And I really look, it's very interesting to go back and think about what has been done and what we think is really novel. Actually, it's not. It was in some form was described before. And he was a surgeon. And as we know, the early pathology literature does come from surgeons. And he actually described this disease. And he was actually one of the key person who was responsible for iodinization of table salt to prevent goiter. So great work by him. But if we go back again to in the literature, the subacute thyroiditis and acute inflammation of the thyroid gland was described as early as 1817, and this is not available, and it's kind of hidden into these monographs, in the surgical monographs. And this is Dr. actually Migzet, who really described this beautiful case of thyroiditis acuta simplex. And he talked about how the thyroid was inflamed, and it really was associated with this pain, and then it disappeared. So this entity has been haunting us for a long period of time. Now, what do you see in this? So clinically, it's very important to know that these patients are genetically predisposed to developing these conditions. This subacute thyroiditis is always preceded by an upper respiratory tract infection. You can have elevated titers of several viral antibodies. And actually, when I talk in international meetings about this in Japan and Turkey, they know this. They deal with this every day. And they're like, oh, so what is novel about it that you're telling us? Because we see this so often. So there are pockets and clusters of this disease. It's interesting that the 70% of the patients have an HLA-B35 phenotype, and which is, you can see that this is really genetically predisposed. Now, there are cases, even with the SARS-CoV or COVID-19, which have caused subacute thyroiditis type syndrome in the thyroid. So this definitely has connection with the viral system. Pain in the thyroid region in 94% of the cases, weeks to months if left untreated. I do want to tell you that when you're getting this history, there is now a great body of literature which shows that some of these cases may not even actually have pain. So you may not even get that history. So getting the history on the lab tests is very important. That hyperthyroidism followed by hypothyroidism is very typical of these. Patients then can have various symptoms which can present as Graves' disease. These are the lab findings: body temperatures, thyrotoxicosis, and antithyroid antibodies, and can be normal in majority of the patients. So not all patients do develop antithyroid antibodies, and these lab tests are very important for the first 7 days. So if somebody has drawn those tests, look back into your charts to really find those tests, because now what you may be dealing with may be normal lab tests in these cases. Radiology looks horrible. These pictures were given to me by my good friend, Dr. Krishnamurthy at the Children's Hospital, because really the Children's Hospital do see these cases. This gives rise to massive hypoechoic and vascular areas, which makes it look very suspicious on ultrasound. And you can see how vascular this lesion is, very mottled appearance and a lot of hypoechoic areas mixed with isoechoic or hyperechoic areas. This is the literature on it. There is definitely FNA cytology described in some of these cases. This is my favorite paper by Solano. It was published in 1997, and it really outlines what you see in these cases. And this is the histopathology, and you can see there, this is definitely has a phenotype of more of a reactive process, but none of these viral proteins can be seen in these cases. So it's still complicated pathology, but I think it's definitely associated with viral prederm disease. Recovery you do see in most patients, as we saw in my case too, but up to 31% of the patients can develop permanent hypothyroidism. I have also seen cases when the patient has history of Hashimoto's for the long time, and then you develop this subacute phenomena on the top of Hashimoto's. So I've seen few of those cases also. Some of the patients may end up developing Graves' disease, and once you have subacute thyroiditis, I really didn't know that up to 10% of the patients are at risk of developing subacute thyroiditis. And I think that is tuned to that HLA phenotype that is in those patients. So what are my conclusions? My conclusions are very general. When you look at these cases, these are the cases that show you back to the basics. Create flow charts in your mind when you're handling this. And I think clinical history for any cytology specimen, for any specimen in pathology, is very important, because you are dealing with, our specimens are getting smaller and smaller by the day, so you're relying on very few cells to look at. Ultrasound features are very important. I always say make the radiologist your friend, and specimen has to be adequate. When you are interpreting a thyroid FNA case or any cytology case, keep a benign lesion in your differential. If you do not remember anything from this talk, please remember that start from the benign and then go to malignant. When you start from malignant and then go to benign, it's very hard to get to the benign lesion. So ask yourself a question, why it is not benign, because that will always help you. And as you know, most of these cases will be called plus. So thyroid cytology or FNA morphology, everything matters. And that is a combination of everything. You just cannot say this is atypical, let's send it for molecular, because that is not a good service for the patient also. Naturally, there's a good cases that you can send for further testing, but history solves everything. Sorry, this is my last slide. We are going through very tough times. And it makes us really think of the best things we have in our life, all the love we have of friends and family. And I really bid all of you peace in these times. But it kind of reminds you how delicate we are and why the social structures, without the bonds of all the race, any kind of orientation or geography, we're all friends. And I think pathology is a great field which really brings us to this platform. So believe in yourself, believe in the universe, whatever your religion is, and your family and loved ones. And I think all of us will pass through this. So everything in your life matters, and every blessing really counts. Thank you so much, Emilio and Rifat.
Thank you so much, Dr. Bellows. I have a question right now from an online audience regarding your presentation. The question is, or rather a comment, Anita from India says she would like to rule out tuberculosis too in a setting of a young patient in India.
Yes, I absolutely agree. I do, to be honest, this was a great, Anita, that's a great question. So, sometimes we do forget being in the US and this stuff that the TB is not such on the back of the horizon on our mind, but I will tell you this has hit me and I've learned my lesson that when you're not thinking of it, that's when it is tuberculosis. Personally, I have only seen one case of tuberculosis on the, as well as I put infection in my differential on FNA of a thyroid, which was a second opinion case sent to me. But I have seen my pathology colleagues from India that I know on the meetings and stuff and have shown me cases. So definitely, great point. I'm very glad you brought that up.
The next question is from Ambarish. That's also for you. Does a clinically suspected thyroiditis require an FNA?
Excuse me, can you repeat it, Rifat?
Yeah, sorry. So the question is, does a clinically suspected thyroiditis require FNA?
So I'm sorry, I still didn't understand the question, but so subacute thyroiditis can recur. FNA, you can make a diagnosis of thyroiditis. But I think when I make a diagnosis of chronic lymphocytic thyroiditis or subacute thyroiditis or any other type of thyroiditis, but these are the two important ones, you have to be very careful that you correlate it with radiology and the lab findings. Granted, the lab findings can be on a spectrum. Some patients, remember the TSH levels have a wider range. So the patient may be subclinically hypothyroid or subclinically hyperthyroid, and they may not totally match because you say, well, this patient is not hypothyroid because the TSH range is very important. So when you're making this diagnosis of chronic lymphocytic thyroiditis, aka Hashimoto's thyroiditis, or subacute thyroiditis on FNA, you really have to correlate all three things together. I mean, four things: clinical history, lab findings, and radiology. And I think that will make that diagnosis on FNA. And you can make this diagnosis as long as you all have your ducks in order. I hope I answered that question. I'm still a little confused by that question. So.
I think the question was, I think maybe I read it wrong, that if it is already suspected clinically that it is thyroiditis, do you still need to do an FNA?
Yes, you do. So what happens when there is a diffuse process which is going through the thyroid, you really do need to do FNAs, because if the clinical history is subdued, it's not a typical clinical history. Remember, lymphomas, anaplastic carcinomas, secondary tumors of the thyroid, when they rotoroot through the thyroid, that means they're destroying the thyroid, they will give the clinical picture of a subacute thyroiditis or Hashimoto's thyroiditis or even acute infection. So you do have to do the FNA. Now, it's a double-edged sword. When you have an FNA specimen, you have to put it together with the history and make that diagnosis. As I showed you in case number 1, if I have only focused on those funny-looking spindle cells and necrosis in the background, I would have gone the wrong path. Then you start to see something else that reminds you of a benign inflammatory conditions. Then you have, so the short answer is, the clinicians in majority of the cases, when there is some funny presentation that doesn't totally match, they will do an FNA, but a good clinician will tell you what is on the top of their list, which is a benign condition. So yes, FNA is indicated when it's not a classic case.
Thank you, Dr. Balos. I see there is a question for Dr. Vargara, if Dr. Vargara is around. And this question is from Ambarish Padi, that who wants to know, what is the principle of Eurovision?
Hello,
Sorry,
Rifat.
yeah, got it.
Yeah. What is the principle?
Right. What's the principle of Eurovision?
Not sure I understand the question, but again, like literature is pointed out, probably the best idea to use this is just to clarify the atypia in cytology. I mean, Eurovision is a fluorescent in situ hybridization technology, and then urothelial carcinoma is one of those carcinomas that is associated with a lot of chromosomal aberration, and that's what the Eurovision points out. The problem is that high-grade urothelial carcinoma, it's not difficult to make that diagnosis when it's there on urine cytology, high grade. So the use of Eurovision shouldn't be used for those cases where we're pretty good on cytology making that diagnosis. So it should be more for those cases in the indeterminate category where we can have a more useful use of this technology. I hope that answered the questions.
Thank you, Dr. Vergara. There is a question for Dr. Jalali. The question is from Minesh, who wants to know, should all branchial cleft cyst-like cytology opt for P16 HPV?
Yeah, so that's a very excellent question. Studies have shown that P16 can be positive focally in branchial cleft cysts, and because P16 from definitive metastatic squamous cell carcinoma can be focally positive in cell blocks, actually my recommendation would be against testing atypical cytology for P16, because if you end up with focal staining, it can be either one of the two. It can be a branchial cleft cyst or a metastatic squamous cell carcinoma. So unless you're sure that it's a squamous cell carcinoma, do not do P16 testing, because it can mislead you into believing that it's an actual carcinoma rather than just a branchial cleft cyst.
There is another question for you, Dr. Jalali. The question is, do you know why cell blocks of HPV cases do not stain as well as surgical slides for P16? And this question is from Mohsin.
So that's another very excellent question. So there's nothing definitive, and this is not unique to P16. Some studies out there have shown that not all antibodies stain equivalently between cell blocks and tissue. The speculation is that most likely the reason for that is that the way we prepare cell blocks is different from tissue. So in tissue specimens, we only expose those to formalin fixation, but in cell block preparation, it's variable, and a lot of institutions expose those to alcohol, so methanol or other preparations that may alter the way cells express the antigens. So that could explain why it's different between cell blocks and tissue, but it's not completely known yet.
All right, thank you. There is another question for you again, Dr. Jalali. This one is from Jeremy, who wants to know, does P16 status in oropharyngeal squamous cell carcinoma change therapy, or does it just impact prognosis?
Very, very excellent question. So in terms of treatment, these squamous cell carcinomas that are HPV related, and I'm not an expert on that, so but I can tell you from my understanding going to these ENT tumor boards, is that they respond very well to radiation and chemotherapy. So if it is a proven HPV related squamous cell carcinoma, some institutions actually treat those patients with primary chemoradiation therapy rather than taking these patients to surgery. At Penn, we actually use robotic surgery to treat these HPV-related squamous cell carcinoma, because if you do robotic surgery, that may decrease the dose of the radiation therapy, and not all patients will require chemotherapy. But as I mentioned, some institution will treat all patients with primary chemoradiation therapy if it is proven HPV related, which also is P16 positive if it's from the oropharynx, because that's the surrogate marker. Now, if it's an HPV negative squamous cell carcinoma from the oropharynx, those don't respond as well to chemoradiation therapy, and if they can be resected, then the best approach to these is resection. I hope that answers the question. That's very basic kind of general guidelines, and as I mentioned, I'm not the expert on treating these.
Right. The next question is for Dr. Bellows, actually. Anita wants to know, how often do you use Thyroid, or do you use it at all?
So we do use Thyroid version 3 at this point. We use it for our AUS plus and suspicious for follicular neoplasm cases. We rarely use it for suspicious for carcinoma cases or malignancy, but depending upon, so you remember, first thing you have to remember that this case, in cases for Thyroid, it's a very expensive test, first of all, to begin with. So you cannot send all your atypical cases for Thyroid or for molecular testing. There's another one, which is the Afirma, that we basically don't use at this point, but rarely it does get ordered. So if the radiology suspicion is very low and you call it AUS, in some cases, the endocrinologist will offer that patient to come back and have another repeat FNA rather than sending the Thyroid at the time of the FNA. If the radiology suspicion does matter and you are on site, and then you say this looks like atypical by performing rows, then we will draw a sample for Thyroid. Now, in the outskirts from the Penn, there are these other areas where the FNAs are done, where the rows is not available. The radiologist or the clinicians will take a sample for Thyroid along, and depending upon what we call it, then we will send it for it. So the short answer, yes, we use it. We may basically focus on Bethesda 3 and Bethesda 4 cases, some cases of Bethesda 5 also. We do not send it when we call it normal, or when we call it non-diagnostic, or when we call it malignant. But yes, so we do malignant, and I will tell you that it really helps guide the surgeon's hand, because even if it comes as positive, if there is a mutation, which is a low-risk mutation, or the allelic frequency of a specific mutation is low, the patient can get away with having just a lobectomy. So you do not need a total thyroidectomy, which is associated with at least 6 or 7% cases of hypoparathyroidism.
Here's the last question for you again, Dr. Bellows. So this time is from Dr. Gopendra. He's a good friend of mine in Delhi. So who wants to know that when sometimes you have very little colloid in slides, how do you differentiate follicular neoplasm from adenomatous goiter? And he finds it difficult.
So I have to tell your friend that that difficulty is universal. So it's not just him. So you are not alone, sir. It's all of a difficulty. So, you have to go to the basics. If you look at the adenomatoid hyperplasia in the thyroid, there are nodules that if I take a high power, I can convince you that this comes from a follicular carcinoma or a follicular adenoma or adenomatoid nodules. So I personally may be the wrong person to answer that question because I have my own opinions, and I think I'm old enough to have opinions. If you focus on colloid as the marker for a benign thyroid condition, I think that is not a good idea. You look at the cells. benign nodules in greater than 70% of the cases will give rise to a heterogeneous population of the cells. That means you have small dark follicular cells arranged in sheets or small structures, and then you have some cells which have a little bit more cytoplasm. So there will be very heterogeneous population. You look at the cells first. It's very hard to retrain yourself when you have been doing it for a long time. But if you focus on heterogeneity, to me, that is a better and a reproducible marker for a benign thyroid nodule than saying this one does not have a watery colloid. That means this is going to be atypical FLUS or a follicular neoplasm versus this has a lot of watery colloid and this is going to be benign. Thyroid tumors, even carcinomas, are well differentiated carcinomas, most of them. They can form follicles, and the follicles, when they form follicles, they have colloid in them. So relying on that, I'm not saying it's not helpful. The colloid is there. Look at the cells first. So for me, the heterogeneous population is much more important. Then you look at the background and then you say, I'm thinking based upon the cell population, it's benign. Now the colloid, the macrophages, whatever you think matters. So my approach to that, it's not a perfect approach because the cytomorphology and morphology is not an exact science. There's a lot of variability, especially when you're dealing with AUS FLUS and versus benign or versus follicular neoplasm. But I carry that approach, and for me, that has worked so far. That means I'm still have not been asked to wear a three-piece suit and go to the court for this. But I think that to me is a better approach.
I think that would be the last question, and there are some more questions there. I'm sorry, we would not be able to answer all, and you can actually reach out to any of the speakers directly, or if you have questions, you can also send it to us. We will pass them on to Dr. Balot, Dr. Jalali, and Dr. Vergara. They would be more than happy to answer your questions. And thank you again, all three of you, for this excellent discussion on so many important points, raising clinically challenging situations. And thanks for your time. And you three will be very happy to hear that you had hundreds of viewers from so many different countries, and I could actually keep track of at least viewers from 20 different countries, from as far as Nicaragua, Philippines, Egypt, UK, Turkey, Myanmar, just to name a few. And thanks to all our viewers for joining us. And as always, if you like our lectures, please subscribe to our YouTube channel, that is Pathcast, and also follow and like our Facebook page. And please subscribe to our newsletter so that you can stay updated about all the upcoming lectures. And our next lecture is coming up on June 19th, that is this Friday. So Dr. Joseph Rabban, who is professor of pathology at UCSF, he is going to present the third lecture in the GYN Path lecture series, and the title is Uterine Mesenchymal Neoplasms, Recognizing the Wolves in Sheep Clothing. Just remember the time will be a little different. That would be 1 p.m. Eastern Time. Hope to see you all again. Thank you so much. And thank you again, Dr. Balot, Dr. Jalali, and Dr. Vergara.